Welcome to tonight's Cafe Scientifique at Stanford Blood Center. My name is Kevin O'Neill in the Marketing and Communications Department. Stanford Blood Center was part of the pathology department within the Stanford School of Medicine until the end of September. We are now a part of Stanford Healthcare. Stanford Blood Center is the primary supplier of blood products to Stanford Healthcare, which is the second largest user of blood products in the nation, as well as 2 other hospitals in our community. Of the approximately 70 blood centers in the United States, few have a history that includes research as we do. The research facet of our mission has been a springboard for many milestones and industry-leading discoveries made here. Our success would not have been possible without our faithful blood donors, many of whom are here this evening. Thank you all. Now I would like to introduce to you tonight's speaker for our discussion on human memory. Dr. Sharon Shah received her bachelor's degree from UC Berkeley in cognitive science and molecular cell biology with an emphasis in neurobiology. She went on to obtain a master's degree in physiology and her MD from Georgetown University. She trained in neurology at UCLA and Stanford and completed a clinical and research fellowship in behavioral neurology at UCSF, where she focused on identifying biomarkers for genetic forms of frontotemporal dementia and caring for patients with movement disorders and cognitive impairment. She is a clinical assistant professor in the Stanford School of Medicine's Neurology and Neurological Sciences Department, specializing in memory disorders. She co-directs their Huntington's disease and ataxia clinic. She serves as director of the Behavioral Neurology Fellowship Program and medical director of the Stanford Neurosciences Clinical Trials Group. Beyond sharing her stellar credentials and multifaceted responsibilities, I would be remiss if I didn't share comments from her patients. Here are the comments from 3 of them. Dr. Shah was excellent. She provided a thorough explanation of my test results in words I understood and made meaningful recommendations for my future well-being. She patiently listened to my concerns and alleviated them with explanations, discussions. Having had many interactions with medical providers, she was clearly one of the best. We love Dr. Shah. We fly up from Southern California every 6 months to see her. She is excellent at explaining where we are with my wife's LPA. And finally, Dr. Shah is the model from which all doctors should aspire.
You're going to make me blush before I even start talking.
Direct, honest, confident, and kind. Please welcome Dr. Sharon Shah.
Thank you, Kevin, for that really wonderful introduction. That is, like I said, going to make me blush already. So thank you for all coming today, and thank you for the Blood Center and Kevin for inviting me. I really appreciate the opportunity to talk to you and share with you what I know and be able to answer any questions that you have. I think a common concern for most of the patients that come in to my clinic is, I'm having memory problems. Where am I? Should I be worried? So today, I'll talk about defining a few terms. What is normal aging? What does dementia mean? What is Alzheimer's disease? What's mild cognitive impairment? I assume that most of you have heard many of these terms. How do we go about a diagnosis? What do I do in the clinic every day? What are our treatment options? What are any potential experimental medications that I think are exciting and potentially possible that will come to fruition? And what can we do now to prevent ourselves for the future? So I think in an hour, let's go through all of this. So here's a common concern. 71-year-old woman comes into my clinic complaining of repeating questions and trouble remembering names of people. Is this normal aging? Is this dementia? Is this Alzheimer's disease? These are very common questions in my clinic. So let's define what normal aging is. We know there's some things stay the same as we get older. What we call these crystallized abilities, our acquired knowledge, what we call semantic knowledge, our knowledge about the world. And our vocabulary, how we might read the word grotesque, for example, or how we might read the word night. Our vocabulary is relatively stable, but there's a slow decline after age 80. What happens as we get older, though, these fluid abilities, our ability to learn new information, working memory, which is sort of what we hold in our brain without writing something down. So remember when we used to actually dial telephones and the 7 digits that we would try to remember without writing it down? That's our working memory. And that's probably why we have 7 digits for a phone number, and that's sort of the average working forward digit memory. Our efficiency in learning new information can have a slow decline, and our processing speed, so how quickly we're thinking, starts to have a slow decline from our mid-20s to our 60s. So all of us are already past that. And then after 60s, there is a more rapid decline. So that's sort of the pattern of normal aging. And then what's dementia then? Well, dementia really means that you have a change in thinking, a cognitive ability beyond that normal aging. So sort of beyond what are the normal reference points. But it's causing a functional decline. What do I mean by functional decline? Well, what you have to do to manage your household. You have to remember to pay the bills. If we're on medications, we've got to remember to do that. Go to the grocery store, get those things done, and all those chores that we need to do. A lot of us imagine what dementia is in its most advanced or severe form, when people are having trouble bathing themselves, feeding themselves, dressing themselves. That is dementia also, but it's more of an advanced setting. So that mild dementia could have those subtleties that make it harder for people to live independently. So let's contrast this to mild cognitive impairment. That's the same thing. There's a cognitive change beyond what's normal aging, but it doesn't impair functional ability. People are still able to work, live on their own, not forgetting medications, things like that. And then we can contrast that to normal aging, which is where we have some of the slower processing speed, our working memory declines a little bit, maybe a little more of that word finding, but no change compared to other people in your age group. And so in that spectrum, we think of normal aging and then declines to mild cognitive impairment and then dementia. It's on this spectrum. It isn't one day you're mild cognitive impairment and the next day you're dementia. It's just a range. So then I usually like to describe that dementia is an umbrella term. People try to ask me what's the difference between Alzheimer's disease and dementia. Well, dementia is really a description of that cognitive decline that has that functional decline, but it doesn't define the underlying cause. And that underlying cause can be numerous. It could be Alzheimer's disease, that's the most common one, but it could be other things like Lewy body disease, vascular disease, in which you have strokes in your brain, frontotemporal dementia, Creutzfeldt-Jakob disease, which might be related to mad cow disease, chronic traumatic encephalopathy, where you might hear about these football players with repeated head trauma, and they have a dementia syndrome. These are only to name a few, so there's several. So dementia is that umbrella term. Let's go back to my patient, Mrs. G. So let's hear a little more specifics, because then maybe we can help define what she has. So she's 71. We always, in neurologists, want to know if they're right-handed or left-handed. Right-handed woman with 2 years of memory changes. Now, she's been having repetitive questioning. She might ask the date 5 times a day. She's forgetting conversations. She once got lost in the mall by herself. She's having difficulty learning her new cell phone, though I think all of us have problems with that. So that's not, I wouldn't put a lot of stock into that one. She's become more irritable. And ironically, her husband said she used to be really critical of him, but now has become more mellow and not nagging him as much. And her husband had to take over the bill paying because she was missing payments and making mistakes. So, based on what we talked about, does she have dementia? Yeah, I see a lot of nods. That functional decline, where she's not able to manage that household as well, we're thinking that she's probably in this mild dementia. So what do I do in my clinic when I hear these complaints? Well, in 2001, the American Academy of Neurology put out special guidelines to suggest what every neurologist or every doctor should do when someone has a cognitive complaint. The first one is do an image, a CT scan or an MRI scan, really to rule out a tumor or a bleed. We want to screen for depression because that can cause cognitive problems. We want to screen for things that are treatable. So depression is treatable. A B12 deficiency is treatable. Thyroid abnormalities are treatable. Syphilis is treatable, but not that many people have neurosyphilis these days, so they say if you're at risk. The problem with these recommendations, that's 15 years ago, and there's a lot more that we know about dementia, and there are a lot more imaging and spinal fluid techniques that can tell us more about what this potential cause could be. So what do I do in my clinic? I really want to get that history, that information. It tells me more about what's going on. I usually ask for not only the patient to come in, but another informant, a family member, a friend who really knows the patient well. I want to hear about timing. Has it been progressive? Has it been static? How long ago did it occur? What are the current symptoms now? Are there mood disorder? Because we want to screen about depression. Are there other behavioral changes? How is sleep? Sleep can impair cognition for sure. Sleep apnea, untreated, can actually cause cognitive decline, and if it's treated, that could be reversible. We want to hear about the functional status so we can define whether it's dementia or not, and that has other consequences. What medications are people taking? There are common medications that we know can cause cognitive disorders. Opiates, like pain medications, benzodiazepines that are like Valium, Ativan, and things that are anticholinergic, so antihistamines, things like that could worsen memory potentially. I want to do a good neurological examination. A lot of people who do have dementia don't necessarily have problems, but there can be some Parkinsonian-related syndromes. And I need to do cognitive testing. So this may not project well because of the light, but I'll show you another. What I want to do some in the clinic cognitive testing, and there might be some times when I refer to a neuropsychologist to do more in-depth cognitive testing, because we really need to define whether there is a cognitive impairment. And I want to do the lab test with the thyroid function, B12 levels. And because people don't necessarily have neurosyphilis that commonly now, we don't have to do it. But if there are sexual risk factors, we would probably want to check for syphilis and HIV, because that is more common. And then in terms of imaging, I would prefer an MRI because the quality of the MRI is much greater than what we can get from a CT scan. But if someone has a pacemaker or precludes them from getting that, then I'll settle for the CT scan. And we'll talk a little bit more about this, but spinal fluid, the CSF, that's what stands for cerebrospinal fluid, or a PET scan, those are options that we can employ to help better diagnose these syndromes a little bit better these days. So let me talk a little bit more about cognitive testing. So this is the Montreal Cognitive Assessment. I often do this in my clinic. This is just a portion of it. And it gives me a little assessment about executive function, multitasking. So we have to go from 1 to A to 2, then to B to alternate back and forth. I'm not going to test you here. We have to copy this, and I don't want to give you all my secrets if you're going to come see me. But we are going to test you if you want to for a moment. So I usually test people with a word list. That's a memory test. So I'll give you 5 words, and I'm going to ask you for them in a few minutes. You can just think in your head. We won't really test you here. So I'm going to give you truck, banana, violin, desk, and green. Commit that to memory, and I'm going to distract you in the meantime. That's what I do in the clinic, distract you. Desk. Okay. There you go. Done. Okay. In the vault. All right. So let's talk about bedside versus neuropsychological testing. The bedside screen is what I would do, like that Montreal Cognitive Assessment. A quick sort of 5-word list, have you do some multitasking. It might take 5 to 10 minutes. These are great. They're easy to administer. They're really fast. A neurologist could do it. A nurse could do it. A primary care provider can do it. It gives us some quick information. It doesn't always account into education or baseline ability. So it's really insensitive to really subtle changes. it's really quite dependent on language. So if we're communicating in English and they're not a primary English speaker, it might make it harder to get an assessment. And it can miss some cognitive domains. When the cognitive domains I think about that we really want to test, besides memory, would be visuospatial function, so how you navigate in the world or copy a picture. We think about language, how you produce language, understand language, repeat sentences. We think about executive function. That's that multitasking, organizing part of the brain, too. And neuropsychological testing is when usually a PhD or a psychometrist does formal cognitive testing. We usually get a baseline, so your general IQ, what we'd expect for how you would perform. And we get all those different domains, including an assessment of emotions or depression. And that cognitive testing compares you to other people your age. So then it tells us whether this is normal aging or is there more of a deficit than what we would expect. The caveat there is that could be lengthy. Some people take 2 days to do it. Some people just do it in a few hours. Here at Stanford, our neuropsychologists streamline the patients that I see to a few hours. But it can be expensive. So it really depends on the patient. So what would we expect to see in someone who has Alzheimer's disease? Most commonly, we see someone who has memory loss. That's what we'd expect. Other common symptoms would be word-finding problems. So that tip of the tongue, what's that thing that we put the trash in? Oh, it's the garbage can. That's that common word-finding problem. But we hear that in normal aging, too. So it's not necessarily specific, but it is common. There can be some navigation problems. Depression and anxiety are common as well. This diagnosis is really usually in the right age group without another medical explanation. That's why we do all those screening measures for treatable causes. And once we've ruled those out, then we really have to think about, is this the right diagnosis? In a specialty clinic, such as one at Stanford, the accuracy is quite good. Biomarkers, which are the things that we're going to talk a little bit later about in this talk, are ways to identify the right pathology without having to take a piece of your brain while you're alive. That pathology is the way to only get that 100% diagnosis. But we're trying to do better with while you're alive, without taking that piece of your brain, how can we get the right diagnosis? So let's remind ourselves of what the pathology is. So what we see, and you might read about in the literature, is about these amyloid plaques here. Beta amyloid is a protein. It forms these clumps, and it forms these plaques. Tau is another protein, and it forms these tangles here. That's what they call these flame-shaped tangles. And those two both build up in the brains of people who have Alzheimer's disease. We have criteria to help diagnose Alzheimer's disease. These criteria are recently updated in 2011 to help us better predict that underlying pathology. We need to have someone that has dementia. You must have that functional decline to make that diagnosis. People must have slow progression with the cognitive impairment. And that cognitive impairment is usually in memory. We call that amnestic presentation. They must have another deficit in another cognitive domain, like visuospatial function, language, etc. But what we're recognizing more is that there can be non-amnestic forms of Alzheimer's disease, meaning that people can have a primary problem with word finding. It's so pervasive that it's causing a dementia syndrome. That's what we might call primary progressive aphasia. Someone can have a primary problem with visuospatial function. You can see people have problems copying these figures here, might get lost, might have trouble seeing things. Some people might have a primary problem with executive function, which is that multitasking, organizing part of the brain. We usually think about other diseases when we hear these as the primary presentation, but as we've learned more with autopsy studies, that we can still have that same pathology of Alzheimer's disease with the amyloid and tau when people have these presentations. So how do we predict when these patients have different presentations? How do we predict that they have Alzheimer's disease? Well, the update of the criteria in 2011 included biomarkers. We can now have ways to predict that someone has amyloid in their brain while they're alive. We have ways to predict that someone can have tau or evidence of neuronal damage in their brain before they pass away. And if we have evidence of both amyloid and evidence of neuronal injury, then our prediction of probability of having Alzheimer's disease is quite high. So it's been about 5 minutes, I think. Does anyone remember those words? Yes. Yeah. Great, great. I won't test you, but just to remind you, truck, banana, violin, desk, green. Okay, you passed, great. So let's talk about biomarkers. So what are they? Really, it's the two main categories to predict the underlying Alzheimer's disease pathology. So these biomarkers would be to detect presence of amyloid in the brain. We can do that by taking some of the cerebrospinal fluid. That's the fluid that surrounds your brain and your spinal cord. And we can go in your lower back, take some of that fluid out, and look for presence of amyloid. We can do a PET scan, where they inject a ligand to bind to amyloid in the brain, and then it lights up, and it would look a little like this. The hot spots would be red. We could do measures of neuronal injury, damage to the brain, by checking the cerebrospinal fluid of tau markers. We can do a glucose PET scan, or look at the structural MRI that I normally get for all my patients and see if there's atrophy. And I'll show you here. It's a little bit bright here, but there's atrophy in the hippocampus. And I'll show you another slide a little further down. So we'll talk a little bit more about cerebrospinal fluid biomarkers. When I get this for a patient, I can get levels of two things. The amyloid beta, and in Alzheimer's disease, it actually decreases in the spinal fluid. We don't really know why. You would think it would rise because it rises in the brain. We don't really know why. We get evidence of spinal fluid tau and phosphorylated tau. The tau represents neuronal damage, but the phosphorylated tau is more specific to Alzheimer's disease. And it can be quite sensitive and specific for predicting this diagnosis. So amyloid beta is sensitive 86% of the time, specific about 90% of the time, to distinguish that you have amyloid in your brain compared to people who are normal and don't. The caveat is that you can have amyloid in your brain if you're normal, without any cognitive problems, in about 25% of the time. So in and of itself, it could be worrisome unless you don't have the right clinical context. It also doesn't exclude a secondary disease. So if you have amyloid in your brain, we usually think maybe you have Alzheimer's disease, but it doesn't mean you don't also have Lewy body disease, chronic traumatic encephalopathy, some secondary dementia syndrome. And we can't really use these levels to track progression. So we say, oh, maybe we get it once. Do I repeat it to see if therapy is working? We don't necessarily do that. The tau, the total tau, I mentioned there were two, phosphorylated tau and total tau. It's non-specific. It's a measure of neuronal injury or damage to the brain cells, but it can be elevated in other diseases that also cause neurodegeneration, such as Creutzfeldt-Jakob disease, frontotemporal dementia. The phosphorylated tau is more specific. It's about 92% specificity. So it adds, in combination with amyloid and the total tau, a better prediction of underlying pathology. We can also use amyloid PET scans now to detect presence of amyloid. So people who might be squeamish about getting their lower back poked, they might say, okay, let me get a PET scan. There are 3 FDA-approved tracers available now, florbetadine, florbetapir, and flutamidamol. And it's really to look for atypical Alzheimer's disease, usually in people who are less than 65. And why do I say 65? Because as we get older, the likelihood of having amyloid deposit in our brain increases. And people, like I said earlier, can have amyloid in the brain and be clinically normal. So as we get older, the likelihood of having amyloid in the brain increases, and so it would change our prediction. For example, someone who's less than 65, and it's unusual to have amyloid in your brain, then we'd say that's probably a stronger predictor of having Alzheimer's disease than someone who is 80 without any cognitive complaints. The biggest caveat, which is why I don't order it very much, is that it's not covered by insurance. And at Stanford, I think it's upwards of probably $3,000 or $4,000 to pay out of pocket. Some people do, but if you don't want to spend that, then it might be the spinal fluid. But we don't always need to have it. It's usually for these atypical cases where we think it's Alzheimer's disease, but we're not quite sure because maybe the presentation isn't that amnestic presentation, or maybe we're young and we think we don't typically have Alzheimer's disease at age 59 or something. Here's just to show you what an amyloid PET scan would show at bright and hot, that's the red, versus someone who has a different diagnosis, frontotemporal dementia with ALS. Because I said it's not covered, I thought I would mention this study. This is a study called IDEAS, led by Gil Rabinovich and the Center for Medicare and Medicaid Services that are working together. So industry, CMS, and academia are working together to see if we cover these amyloid PET scans, does that change management? In the past, Medicare decided not to cover this because we don't have a cure for Alzheimer's disease, unfortunately. I hope that's not new information for you. But if we cover it, does that help change management? Does it change it so that you don't go to repeated doctor, get repeated MRIs, get lots of hospital admissions? We'll find out. So we're trying to recruit lots of patients, about, I think, 18,000 patients across the country that have a good indication to get this, and we'll see what happens. So we're talking about amyloid PET scans. What about tau, the other protein that builds up? That's experimental right now. That hasn't been proven to really help us distinguish whether there is truly tau in the brain or not. It hasn't been FDA approved yet, but there's a lot of research going on to try to develop these tau ligands. And you could potentially not only identify Alzheimer's disease, but chronic traumatic encephalopathy, those football players, as I mentioned earlier, have tau build up in the brain. So maybe we could use these tau PET scans in the future and decide whether they should continue playing or not. Or tau is present in other types of frontotemporal dementia, too. There have been treatment trials aimed at tau diseases as well. So this is what we potentially might see in a tau PET scan, as well as there. So we'll talk about a different type of PET scan now, fluorodeoxyglucose PET scan. So that's not injecting a tracer to bind to amyloid or to tau. It's injecting glucose and seeing how your brain metabolizes it. In people who are normal, it should metabolize it sort of symmetrically all over. In people who have Alzheimer's disease, the posterior part of the brain, so this is a side view, that's the front, and here's the back. The posterior part of the brain has less metabolic breakdown. So we call it hypometabolic in the posterior region compared to normal controls. It also increases accuracy in distinguishing Alzheimer's disease from other types of diseases. Medicare usually covers it if you're not sure if it's Alzheimer's disease or frontotemporal dementia. We don't necessarily just do it routinely for everybody, but if someone has an interesting presentation, an unclear presentation, we might add that. And just to show you what it might seem like, so the bright red would be what an Alzheimer's patient might have. So this is a side view, so that back part of the brain. Compare it to someone else, like this is Lewy body disease, where you don't see it, the hypometabolism, so specifically. Frontotemporal dementia, it's frontotemporal dementia, so we tend to see that there's hypometabolism in the front part of the brain, or the temporal lobes. So what do we use to treat Alzheimer's disease? Like I said, we have no cure. We have treatments that are sort of symptomatic. The main category are cholinesterase inhibitors. Those are medications to boost acetylcholine levels in the brain. We know that there's a deficiency of acetylcholine. That's not curing the disease, unfortunately. Curing the disease might be getting rid of that amyloid and tau. We know there's a deficiency of acetylcholine, but fixing the deficiency doesn't fix the disease process. We're trying to hold on to what's left. So the common ones are donepezil, also known as Aricept, ribostigmine or Exelon, and galantamine is an older form of the disease. Common side effects would be nausea, vomiting, diarrhea. That doesn't sound fun at all. Usually, though, it's at higher doses, so we start slow and then increase the dose. It can rarely cause a side effect of slowing your heart rate. The other main category is memantine, also known as Namenda. It's really used to boost NMDA levels in the brain. And sort of, we're not sure how it works, but maybe reduce excitotoxicity, meaning reducing neuronal damage. It's indicated for moderate to advanced Alzheimer's disease. One thing that I often do, besides prescribing these medications, would be thinking about depression. Depression and anxiety are very common in Alzheimer's disease. And I would be remiss if I didn't address that too, because depression and anxiety can also cause cognitive impairment. So what do these drugs do if it's not curing the disease? So if we know that Alzheimer's disease, this is on the x-axis time, and on this y-axis is a cognitive score. Essentially, that the worse it is, the worse off you are. And so we know that with time, people get worse. So this is a placebo. And then with the donepezil, that people have less of a decline over time. So it sort of shifts things a little bit. But so I try to tell patients not to expect that you're going to improve. Because a lot of people come to me and said, I tried this medication and I stopped it. It didn't really help. It's actually not necessarily supposed to improve your memory, but sort of in the future, you're not as worse off as where you would be. So we don't really have any disease-modifying agents right now. So what we have is, if this is over time, we just showed something like how you would function or abilities. And the symptomatic treatment is what we have. This is what we have with the cholinesterase inhibitors. But what we'd love to have is a disease-modifying agent. So that shifts that curve or even improves things. But we don't have that as of yet. What do I tell my patients besides these medications? I really tout the benefits of exercise. I'm going to show you a research study that I think when I tell patients makes them, we all know exercise is good for us. We all know we maybe aren't doing enough. But this research study from 2011 took two groups of people. These were older individuals, average age around 67, who didn't have memory problems. And they took one group and said, why don't you do stretching? The other group, why don't you work maybe on a treadmill a few times a week? And we'll measure your hippocampus and have you do memory tests. The hippocampus is that memory center of the brain. We know that it selectively atrophies in Alzheimer's disease. And in normal individuals, as we age, we lose about 1% of the hippocampal volume per year. So after 1 year, the stretching group lost about 1% of the volume of the hippocampus. That's normal. But the exercise group not only didn't lose, they gained 1% of their hippocampal volume. So that's a net difference of 1 to 2%. Made your brain younger. And they did better on memory tests. So this is why, even though I'm tired, I'll go home and I'll exercise when I leave here tonight, because it's good for our brains. So in people who already have hippocampal damage, does it reverse it? I don't think so, but it could probably really slow it down. And research studies are demonstrating over and over again now that it's really slowing decline. So there was a recent, I think, study on mice that just came out that demonstrated that aerobic exercise helped their cognition more than weight training or interval exercise. The other thing that I tell my patients, you've got to socialize, you've got to stimulate your mind. So socializing is spending time with people, really, interacting with people. When you think about other people's opinions, ideas, it really makes you think in a different way than if you were passively, say, watching the news all day. Stimulating your mind, too. Passively reading, watching the news, that might be good, but it doesn't really cause you to analyze things. So people always ask me, should I do brain games, Lumosity, Sudoku, crossword puzzles? Nothing is proven. No one thing is proven, but using your mind is proving to help slow progression. Besides the patient, the family is my patient. I really try to educate the patient and family about what's expected, what's normal, talk about support groups. Because a patient might lose their memory, they might forget the things I tell them in the clinic. So we really want to have family members or loved ones or friends really support what we say, education, as we talked about. But we also need to give that family member some respite as well, because it could be a 24-hour, 7-day-a-week, 365-day-a-year job. We also want to plan for the future. So whenever someone has a memory problem, whether it's very subtle or more advanced, you really want to plan ahead and think about what potential risks could be involved. So someone who's managing their own finances and has a memory problem, I tend to warn them, you know, you may not have a problem now. Something could happen down the line. We don't want to wait until something changes before we said, oh, we could have, or oh, we should have. A lot of people might get their lights turned off, you know, their heater turned off. I have a patient who got a cashier's check for $100,000 because she wanted to move her money from one bank to another. She put it in her purse and forgot that she left it there. So the bank is obviously not going to give you a new check for $100,000. So those can be serious consequences for a simple mistake. So we try to plan ahead in terms of money, medication administration. So if someone's taking their own medications, maybe they're fine, maybe they have a great system. But it might be nice to have someone double check so you're not making mistakes and overdosing or underdosing. Same thing with driving. I don't want to get in too much detail here, but in the state of California, we have to report a dementia diagnosis because someone may not be safe. And I never like anyone to blame me, so I leave it to the DMV, but that's what we have to report. But it doesn't mean that someone's automatically unsafe if they have dementia. It's just that you potentially could. So we want to make sure that everyone is safe on the road. We want to think about what the patient would want for the future in terms of their own health care, what they would want in terms of where they would live, that sort of thing. So let's go back to our patient, Mrs. G, who had this Montreal Cognitive Assessment. She scored 17 out of 30. Normal is 26 or more, but again, it's not age-adjusted, it's not education-adjusted necessarily. But I'll show you, she had trouble with this sequencing, the 1 to A to 2 to B, and then sort of lost where she was supposed to go. She's supposed to copy this 3D cube, and she had a little bit of difficulty. This clock is supposed to say 10 past 11, and she had problems with the hands of the clock. She did okay with naming these animals, but with the word list, which you can't see very well, she got 0 of those 5 words. I gave you different words, but they're similar. She couldn't get any of those words, and when I gave her hints, like if you didn't remember violin was one of the words I told you, I might say one of them was a musical instrument. Does that ring a bell? Was it piano, violin, or drum? When I give them those hints, and it helps tell me what parts of the brain is working or not working, but for her, it was gone. Then I did an MRI, and it's demonstrating hippocampal atrophy. As I mentioned earlier, that hippocampus is the part of the brain that selectively degenerates or atrophies. And I wanted to show you, and it might be hard because it's so bright. The hippocampus is this structure here, and in Greek it means seahorse, so it's like a little tail. So what you can't really see very well is that it is full and plump in this sequence. Whereas here, you only see this little strip, and that strip. This black is the cerebrospinal fluid that's filled up the space because the hippocampus shrunk. Here you might see it a little better because the hippocampus is this strip here, and that white space is how much it's atrophied. Here it's dark, but you can see that there's no white space by comparison. So it's really quite atrophied. Let's talk about Alzheimer's disease. I already mentioned it is the most common dementia. And age is that biggest risk factor. So above the age of 65, 1 in 9 people, I say maybe 1 to 2% of people have Alzheimer's disease. Above the age of 85, I tell my patients 30 to 50% of people have Alzheimer's disease. So it's a huge number. People used to say, oh, we get older, we lose our memory. Well, it might be because as we get older, more people tend to have Alzheimer's disease, but we know that there is normal cognitive function that people can have. It's really affecting a lot of people, over 5 million Americans, over 35 million people worldwide. It's the 6th leading cause of death. So we can see that breast cancer, decreasing, prostate cancer, decreasing, heart disease, decreasing, stroke, decreasing, HIV, decreasing. Alzheimer's disease is increasing. Women are particularly affected. 2/3 of Americans with Alzheimer's disease are women. Women are more likely to be caregivers, unpaid caregivers, 24-hour care, and 20% of women caregivers quit their work to become a caregiver. And if we talk about the lifetime risk of Alzheimer's disease in someone's, say, 60s would be 1 in 6, whereas breast cancer is 1 in 11. So we used to be most worried about breast cancer, but Alzheimer's disease is just rising. We've talked about the risk factors, that age is the most common risk factor, because you saw with those numbers, as we get older, more and more people have Alzheimer's disease. Unfortunately, we can't help aging. Genetics, and we'll talk a little bit more about that in the next slide. There are certain genetic factors that increase the risk for developing Alzheimer's disease. History of head trauma can increase the risk of Alzheimer's disease. Vascular disease can increase the risk, and lower education can decrease the risk. increase the risk of Alzheimer's disease. Yeah, what? Let's restate that. Lower education increases the risk. Most of these you can see are non-modifiable risk factors. We can't do anything about aging. We can't do anything about our genes. We can do something about education. So someone, this was published I think in 2015, looked at a bunch of research studies. They performed a meta-analysis looking at 323 articles to see what are the modifiable risk factors for Alzheimer's disease. It's sort of mixed. I don't know if you can see it very well because I can't. So essentially, the risk factors that they found, grade 1 was like more likely, grade 2 less likely. The risk factors would be, say, smoking, low diastolic blood pressure, high BMI in midlife, things like that. Protective factors might be healthy diet, using a statin like a cholesterol medication, cognitive activity. But some things are strange, like ever using alcohol. Something that was a risk factor was, we know, low education. But we said high BMI, but they also say low BMI, really, really low BMI. So I would take this with a grain of salt. These are looking at studies that have been published in the past. But we know that, like I said, education might be a risk factor if you have low, but maybe higher education is protective. And research studies are now demonstrating that more. What are the genetics of Alzheimer's disease? So when people come to me and they said, oh, my mom or dad had it, I think I'm at risk. Well, what does that mean? What age did your mother or father have Alzheimer's disease or have a diagnosis of dementia really helps me. Because as we heard earlier, greater than 85, high likelihood. So if your parent had it at 80 or late 70s, maybe that doesn't increase your risk. Maybe that was the risk factor of them aging. The genes that can cause Alzheimer's disease at a young age are the ones that we usually think about testing for. These are amyloid precursor protein, presenilin 1 and presenilin 2. They cause Alzheimer's disease in your 40s, 50s, maybe 60s, but that's pushing it. These mutations are really rare. And if someone in your family had it, it would have to be a parent for you to inherit it. If you had that mutation, you will get it around the same age. But you have that 50-50 chance. When we compare that to ApoE4, which increases the risk for Alzheimer's disease. So let's talk about that. Apolipoprotein E, we don't really know exactly what it does. Maybe it has something to do with cholesterol. We can inherit a copy, a 2 copy, a 3 copy, or 4. ApoE4 is a risk factor for Alzheimer's disease for sporadic, meaning not people who don't have that family history, or for late onset familial Alzheimer's disease. That 3, E3, doesn't increase your risk or decrease your risk. If you inherit an E2, it lowers your risk. The E4 increases the risk. If you have 1 copy, it might increase your risk 2 to 4 times the normal population. If you have 2 copies, maybe 10 times the risk. The reason why people read about it, study it, is that in research studies, that E4 allele is present in more than 50% of Alzheimer's disease patients. But it doesn't mean that 100% have it. Conversely, it's present in 15% of people who are normal. So it doesn't mean if you have this E4 copy, you're going to get Alzheimer's disease or you will be protected. We just don't know. We just know that's an increased risk. So research studies include that. In the clinical setting, I wouldn't recommend ordering it. One of my colleagues, Mike Gracious, published this article in 2014 that gender modifies this ApoE risk. Essentially, you can't hear the comments, and I won't repeat it. But essentially, women who have this ApoE4 allele have 4 times the risk of developing Alzheimer's disease versus women with the ApoE3 allele. But that risk is not present in men. And then ApoE4 carriers, or people who have that mutation, are more likely to convert to Alzheimer's disease if you have mild cognitive impairment or you're normal, but it tends to be more in women. So there's something about that gender that's increasing that risk, and we just don't know yet. So let's talk about a different patient. This is Mr. M. He's 67, so a little bit younger. He's had memory changes for about a year. He can walk into a room, forget what he was going to do, take notes, misplaces things, repeats himself. Multitasking is hard now. He's forgetting his original task. He works as a realtor, and he's really having trouble with working with more than one client. So he can work, but with a little bit of modification. Is this dementia? Yeah, it's a gray area. We might say he's getting close, but right now, because he's still working, I didn't mention that he's still managing the stuff at home. He's doing okay. So if it isn't dementia, is it normal aging? Well, he has mild cognitive impairment, and I'll tell you that he did have some deficits on cognitive testing. He had problems with memory. He couldn't remember those words. When I gave him those hints, though, he actually got them. But he did sort of almost perfectly on the rest of that test that I showed you. So people with mild cognitive impairment have this proven cognitive decline, more than what we'd expect for age, but they don't meet that dementia criteria because they don't have that functional decline. Amnestic mild cognitive impairment, where we have a problem primarily with memory, is the most common and most studied, and we know that amnestic MCI has about 10 to 15% chance per year of converting over to Alzheimer's disease, compared to, say, 1 to 2% of the general population. So it gets us concerned that people are going to convert. Should we give these cholinesterase inhibitors, the same medications that we give to Alzheimer's disease patients, should we give them to people who have mild cognitive impairment? If we know that it's slowing decline, so to speak, would we want to start people earlier rather than wait till they progress on to dementia? One recent review says there's no benefit. But I think that review included all types of mild cognitive impairment. Maybe who didn't have an amnestic presentation, maybe ones who had language problems or visuospatial problems or something like that. Maybe the amnestic ones that are more likely to be underlying Alzheimer's disease, so maybe those are the ones to be more likely to benefit. One study that did look at amnestic MCI showed less hippocampal atrophy when they were taking that medication, donepezil, but they didn't do any different on memory tests. So the jury's still out. I would tend to offer it in my patients if you want to try it, but it's not proven to be beneficial. But I tend to offer it to patients who I think have underlying Alzheimer's disease, because maybe I see that hippocampal atrophy. Maybe I have some biomarkers that are pointing that direction. So what are the experimental medications that we have? Well, a lot of clinical trials have failed so far. Between 1998 and 2011, over 100 medications have been tried for Alzheimer's disease, with only 3 brought to market. One theory is that we're treating people too late. By the time amyloid deposits occur, it's too late. We know that amyloid deposits in the brain maybe decades before we start to see clinical symptoms. So here's a model that is sort of widely accepted now in the field. And let me explain it to you. So the x-axis is time, and the y-axis is whatever biomarker we're looking at. We've talked about the various biomarkers. So in purple is spinal fluid amyloid change, so that drop in amyloid. So we first start to see it build up that we could detect it. And then we can start to detect it in the red with amyloid PET scan. And then we can detect tau levels start to appear with the spinal fluid in the blue. And in the dark blue, we can now start to detect MRI changes, such as atrophy, or see metabolic changes on an FDG PET. And only then do we start to hear about cognitive change, like memory loss. And only after that do we give someone a diagnosis of dementia. So between the onset of the purple and amyloid to the time of diagnosis, that could be 15 to 20 years. So by the time we give someone that Alzheimer's diagnosis and we enroll them in a clinical trial, is it too late? Have we missed our window in treating amyloid if the target is amyloid for that clinical trial? Well, another hypothesis that is out there is that we've been giving people the wrong diagnosis. When people looked at these trials, 25% of these patients did not have amyloid in their brain or did not have Alzheimer's disease. And people were enrolled based on the symptoms the diagnosis, but there weren't any confirmatory tests, and now we have these confirmatory tests such as spinal fluid or amyloid PET scans. So these new clinical trials are now including what we talked about, some either spinal fluid or amyloid PET scan, to make sure we have the right diagnosis, because if a drug fails and you didn't have the right diagnosis, maybe it actually didn't fail. So the current clinical trials are really targeting the two main pathological features. The amyloid, let's decrease it. We can decrease accumulation, have antibodies to bind it and get rid of it. Decreasing tau. Some people believe that there's an inflammatory cascade that gets set off and then sets off this amyloid and tau deposition. So maybe by decreasing inflammation, that'll help. There are now partnerships with the NIH, pharmaceutical companies, private foundations, academia to really work together, because we're learning and more this is going to become an epidemic. We're starting to treat people earlier. And so as I mentioned, maybe dementia is too late, but maybe we need to treat mild cognitive impairment. Maybe we need to treat people who are normal. And so there are some studies out there looking at that. There's one called the A4 that's out there, and there are actually some in the works, where we're looking at people who are at risk. And so those people who are at risk might be, they already have amyloid in their brain with a PET scan, and they have an E4 copy, or they have 2 copies. So those people are at higher risk. There are some of those genetic forms that we talked about, maybe the amyloid precursor protein, presenilin 1 or presenilin 2, where you know that if you have that disease, that genetic mutation, you will get that disease. So they're implementing some of these amyloid antibodies before that age. And we'll see if that delays the onset. So that's occurring now. There's a specific Colombian population where people have one of these mutations, and they know to get it around age 45. So we're going to give this drug before then. So what are the drugs that are targeting amyloid? So this is this amyloid precursor protein, this long blue thing. And it gets cut by these enzymes, usually beta or gamma secretase, into the amyloid piece. And then it clumps up into these plaques. So the antibodies are usually trying to get rid of these plaques, or by decreasing accumulation, maybe you block these enzymes that cut it, so you keep it this long protein instead of cutting it into those smaller pieces. One drug that recently got some excitement in the media was by Biogen, aducanumab, where they looked at people who had mild cognitive impairment and evidence of amyloid on the PET scan, and they gave them this amyloid antibody, and they found that depending on the dose, they would have less decline on cognitive tests and less decline on functional measures, which is the CDR, the clinical dementia rating, and less amyloid buildup. But it has a main side effect. ARIA, which stands for amyloid-related imaging abnormality, E, which is edema, swelling in your brain. And that tends to be higher in ApoE4 carriers. Most of the time, it's asymptomatic. So this is based on phase 1 and phase 2 trials. Phase 1 and phase 2 meaning ones that are looking for safety, tolerability, can we find an endpoint that is working? And now they're entering phase 3 trials to see if this really does what we think it does, and we're participating in that. There are other antibodies that also show promise. So Eli Lilly has a drug, solanezumab. Originally, they thought it has no effect. It failed. But then they reanalyzed that data and looked at just the MCI patients. They basically looked and said there was a delayed start to some people who were on placebo. People who got the drug, and then people who were on placebo, so that's the fake sham drug. But then the placebo group got the real drug, but just delayed. And they found that there is a decline over time in a lot of these measures, but the delayed group never caught up, meaning that maybe something's happening and that's slowing decline. So there's a trial, a phase 3 trial that's planned for mild cognitive impairment. So maybe the milder form, because originally it was including mild cognitive impairment and Alzheimer's disease. Crenezumab is another drug by Genentech Roche, and similarly also found less decline on cognitive measures. It's relatively safe. They didn't find much ARIA there, and there's phase 3 trials that are ongoing also. You may have seen my boss in the media. I think Fox News was filming him today, trying to steal one of my patients and trying to film him with one of them. And so Time Magazine recently published an article about him and a potential drug. I'm getting fielding a lot of questions about this, so let me put some stuff out there. So he does research and has a company, Pharmatropics, where he's looking at something called P75 receptors. Small molecules combine to this P75 receptors, and what it can do is promote survival of the brain cells, prevent amyloid degenerative signals. He's done a study and showed that one of these drugs that works to bind to the receptor can slow degeneration of neurons that particularly are affected in Alzheimer's disease, and even reversed some of that degeneration. It can reduce inflammation and prevent deficits in memory loss in mouse models. So he just completed, I think, a phase 1 trial, which is looking for safety, tolerability, and he's looking next to try phase 2. People ask me, can I participate? It's only in Europe right now. So I think he's predicting in a couple years I might come here if things are promising there. People ask me about ultrasound. This came in the media, I don't know, in the summertime maybe. Can we use ultrasound? Well, we use ultrasound for other things. So this study basically looked at whether focused ultrasound in mouse-Alzheimer's, so basically Alzheimer's in mice, they found decreased amyloid and getting rid of the plaques, and these mice did better on memory tests. While exciting, it's not really ready for prime time. That's in mice. The next step is probably a bigger animal. We need to make sure it's safe in larger animals before we can start implementing in humans to make sure that we're not damaging other brain cells. I only have a few slides left. One other research study that got some excitement too is when one of my colleagues, Tony Weiss-Correa, gave young blood to old mice. He essentially connected the circulatory systems of young mice and old mice. And it's very Frankensteinish, but these old mice acted young, and these young mice acted old. So the old mice did better on memory tests. And because we know, and so actually, he sacrificed the mice, looked at their brains, and there's sprouting of neurons in the hippocampus. So that's very exciting. Because we know people can get blood, and it's safe, we're at a blood center, we actually have a clinical trial that jumped right to humans in phase 1 to make sure it's safe and tolerable in people who have Alzheimer's disease. So we're giving young blood. When people hear about it, they say, that's something too about young blood. So we're giving young blood to people with Alzheimer's disease, see if that's safe and tolerable, but maybe does it help with memory. And my last couple slides are really just to remind you that all dementia does not mean that you have Alzheimer's disease. There are other diagnoses. Under the age of 65, frontotemporal dementia, which we didn't talk too much about, is just as common as Alzheimer's disease. Dementia with Lewy bodies is about 10 to 20% of dementia. Vascular dementia, where you have strokes that build up, and there are some other rarer causes. So it's not everything is Alzheimer's disease, but it is quite common. So in conclusion, I just wanted to mention that there are cognitive changes with aging. Dementia really defines a functional decline. Mild cognitive impairment can be a precursor to dementia. We now have better diagnostic markers for predicting that right pathological diagnosis. We have some treatments. They're not cures, but really I wouldn't discount exercise, intellectual stimulation, socializing. And I just want to thank you for your attention.
Okay, we'll move to our Q&A part of our talk tonight till 8:30. And because we are video recording this, we'd like to get all the questions clearly recorded, so hold the mic fairly close to your mouth. And we will begin with this gentleman, then we'll get there.
First of all, two You mentioned that two-thirds of the Alzheimer patients are women. After adjusting for the fact that women live longer, what is the ratio?
I don't know. It's still higher. I don't know off the top of my head. It's still higher.
Second
So
and last
more,
question then is, why do you distinguish between right and left-handed patients?
Oh, great question. So we know that language in right-handed people, pretty high, maybe 99% of the time is in the left hemisphere. In left-handed people, it's still more commonly in the left hemisphere, but it's more split. So it helps us localize if we're thinking about what parts of the brain are working well or not working well, helps us think about what part of the brain, which side. Yeah.
In one of your early slides, you identified Alzheimer's as a cause of death. How does one die of memory loss?
Yeah, great question. So a lot of neurological conditions, unfortunately, progress to cause motor dysfunction. So it might not just be Alzheimer's disease, but ALS or Lou Gehrig's disease or other common diseases eventually affect mobility. So as the brain starts to spread to get damaged, then people can become bedbound, not swallow. And most commonly, the cause of death is an aspiration pneumonia, where the food goes down the wrong pipe.
Thank you very much. I have a question. Does Parkinson's disease fall under this dementia umbrella, or is that a totally separate?
Great question. So Parkinson's disease, I also think there'd be a spectrum. So Parkinson's disease, to define for everyone, is usually a motor condition in which people can have tremor, rigidity, slowness of movement. There can be some mild cognitive impairment associated with it, so that there's maybe slower processing speed, difficulty with multitasking, things like that. It can progress, though. So that mild cognitive impairment can progress to dementia. We would expect, though, people to have the motor symptoms or just mild cognitive impairment for many, many years before the dementia occurs. It's a buildup of another protein, alpha-synuclein or Lewy bodies. It's also related to another dementia that I had in my slide called Lewy body disease or dementia with Lewy bodies that also has the same protein that builds up, but it doesn't tend to have that motor dysfunction so early on, or if it does, the cognitive dysfunction occurs almost at the same time or within a year.
You referred, I think, almost to the incidence of Alzheimer's these days as epidemic, that it sounded like there's a lot more of it than there used to be. And I'm wondering, is there a lot more of it than there used to be, or are we getting better at being able to tell that people have this?
It's probably both, such that we're living longer. So the likelihood of developing Alzheimer's disease increases just because, if we're living to 100 and 50% of people over the age of 85, but maybe decades ago people were living an average age of 80, so that's part of it. But yeah, you're right also that we might not have been diagnosing it as much. We have newer tools, and people are more aware. They're coming to clinics now and getting that evaluation. I think it's both. But primarily, I think the impetus to get treatments, to really focus on finding a cure, is because all of us are living longer and we don't yet have anything to really tackle this.
You mentioned antihistamines.
Yeah.
Could you speak a little bit more about the cognitive burden of anticholinergic drugs?
Sure. So the reason why we give cholinesterase inhibitors such as donepezil or ribostigmine is because we know there's a deficiency in acetylcholine. Acetylcholine is a neurotransmitter that's used in the limbic system, which is that hippocampus, that memory center, and connecting to the rest of the brain. We know there's a deficiency in acetylcholine, so we're trying to boost those levels so that it can help with that memory and attention and that function. It doesn't fix the disease, but it helps kind of enhance what's already there. Antihistamines can be anticholinergic, meaning that it's decreasing acetylcholine levels in the brain. So it doesn't necessarily mean that your memory will decline if you're taking antihistamines. It's just that it could exacerbate it if you have memory problems. And so in my patients who I'm giving a cholinesterase inhibitor to, I would say let's try to avoid it so we're not counteracting what we're doing. And in people who are concerned about their memory, maybe they don't have Alzheimer's disease, but they're concerned about it, I would say let's try to find an alternate or minimize it, just so we don't exacerbate anything.
In your slide about exercise in the brain, it said basically the volume of the hippocampus goes down 1% over time. At what age does that start?
That's a great question. I don't know exactly. I think it's after midlife, because we said if we live to 100, then you'd have no hippocampus, right? Because it's 1% a year. So it's definitely after midlife as we get older. But I think one thing to note is that we're not using the hippocampal volume as a measure, necessary absolute measure, like, oh, this is the cutoff, now you have Alzheimer's disease. It's clear when you don't have it that you probably have damage and you have Alzheimer's disease. But we don't have an absolute number that everyone should have this volume. And that's why we're not using it as an endpoint necessarily in a lot of these clinical trials.
You mentioned anti-inflammatory, trying to be anti-inflammatory. Has there been research giving people anti-inflammatories, or would you suggest people taking those?
Yeah, there has been research. And so I don't suggest it because it hasn't been proven thus far. And so people have looked at like NSAIDs, and non-steroidal anti-inflammatory drugs that you might get over the counter. People have looked at COX-2 inhibitors, and there's nothing's been demonstrated thus far that proves it, but it might be that they need to focus it. One of my other colleagues has been looking at certain aspects of the mechanism, and you might have to focus it so that the NSAIDs are too broad, we're not sure. Or that maybe it needs to be in combination with an anti-amyloid drug or an anti-tau drug. I'm not sure yet, but thus far we haven't found anything, so I wouldn't recommend just taking an anti-inflammatory drug. Vitamin B12. Okay, he's next, but so it's okay. She's asking about vitamin B12. I don't think you should take it if you're not deficient, but that's why we screen for deficiency. So if you're deficient, you must take it, and so that you can replete it. But if you are normal, you don't have to take it. It won't hurt you if you take more, though.
Okay, thank you. The beta amyloid and tau plaques clearly correlate with the presence, the diagnosis of Alzheimer's. Has there been much successful investigation into the contributing causal mechanism at this point? Or is it simply at this point they correlate and...
Yeah, it's a great question because we have different hypotheses. People call it the amyloid hypothesis because we're not sure if that's what's causing the disease. We know that it's there. So to get the diagnosis, you must have amyloid in your brain, you must have tau, you must have a certain amount to get that on pathology at autopsy to prove that you have the diagnosis. But is that a mechanism because maybe the brain's trying to fix itself and it's building up because it's trying to clean something else up? Is there what's the inciting event? We don't know. But that's why a lot of the trials that are targeting amyloid, because that's the first thing to deposit, if these drugs don't work, these current clinical trials that we're talking about, if all of these are failing now, then we might end up saying the amyloid hypothesis fails or something else that's setting off this cascade.
The question, it's a bit of a shift, but you had CTE as one of the underlying things, and with the recent publicity on the football-related injuries, is that going to help or distract the research and the activity that's going on?
Yeah, I don't think it'll distract. I think it's good awareness, actually. So I'll just say a few words about CTE. So chronic traumatic encephalopathy really defines the dementia syndrome that's associated with the cognitive impairment and a lot of psychiatric impairment that we see in this dementia syndrome with people who've had head trauma. And we don't know how much or how severe it has to be. There can be concussions where you lose consciousness. There can be concussions without loss of consciousness. There can be head trauma without concussions, and we're not really sure. Because of the autopsy studies that have demonstrated even people who are young, who've been playing football for not as long as these professional football players, but people who have finished high school. And there are only a few case reports, but they have the same sort of damage that you see in these professional football players, makes us worried that it's not a lifetime of damage. It could be a short amount of damage that could cause this. I don't think it'll detract. I think it's important to recognize because we know head trauma in and of itself increases the risk for developing Alzheimer's disease too. But if we get better diagnoses, I think it'll help. I think just making awareness of how important our brain is important too. I don't want to be pro or against football. I think we just have to be pro-brain and pro-brain health.
Is there a good understanding at all, sorry, it's me.
Thanks.
Is there a good understanding at all of what actually causes normal cognitive decline in age?
I hate to say it, but you know, as we get older, lots of parts of our body don't function the same way. I'm the first to admit it, right? The brain in and of itself, if you're gonna see, sometimes you see radiology reports of the MRIs of the brain, and we might see age-related atrophy. Unfortunately, there is atrophy that occurs as we get older. So, you know, we're born with a certain amount, we build it as we get older, and then it starts to decline a bit. So I don't know numbers of how many brain cells we have, but we can damage it, you know. So maybe that's part of it. You know, just life, you know. It's a hand-wavy answer, but yeah.
Okay, I have a question. What's good about diagnosis Alzheimer? In the early stage, there's no treatment. Wouldn't this depress the person?
It depends on the person. So there's some people that come to me and their family's very worried and the patient themselves don't have the insight. And I didn't talk too much about this today, but a lot of patients themselves, when they have the disease, don't have that ability to recognize that they have a problem. Maybe in mild stages, some people have a little bit of insight, but as the disease progresses, a lot of family might say they're in denial. And I try to keep telling them, you can't remember, but that's not going to help. They can't remember that they can't remember, but the ability for the brain to reflect upon itself has declined. So it might be helpful for the families also, planning for the future. Should we move to an assisted living? Should I get extra help? Is it just normal? Am I being crazy? You're right, we don't have a cure. We don't have great treatments. So some people might say, I don't want to know. And I definitely have patients who come in and say, if this is the diagnosis, I don't want to know. They want me to tap around it. But families do want to know. Or some people say, I really want to know. I want to plan for the future. I want to get all my ducks in a row. Or I want to enroll in clinical trials. I want to do everything I can. You know, I want to get my finances in order. I'm going to exercise. I'm going to do all this. I want to come to Stanford because I want to know what's on the cutting edge, that sort of thing. It really depends on the person, too. But you're right. Without a disease-modifying agent, there's less of that push.
But when you say it's very expensive, what's expensive and how expensive? The tests for Alzheimer?
Oh, the test for the PET scan in and of itself. So the amyloid PET scan is expensive. Just a nuclear medicine scan, a PET scan is expensive. So it's $4,000 or something dollars. It depends on where you go. But you could get spinal fluid test, and that's covered by insurance. But I don't think you have to have that. If you have the right clinical symptoms and the right age with the right MRI, all the tests are other negative, then we might say you have the diagnosis. Not everybody has to get this. And that's why I say it's usually an atypical patient, usually younger, that we do some of these extra tests. Yeah.
On a slide for risk factors, you showed that a risk factor is having a BMI less than 30.
Yeah.
What is the conjecture behind the physiology that if you're not obese, you have a risk factor?
Well, I think that's why I pointed out there were two. One was there was a less than 30, but there was also high BMI in midlife in that same risk factor. So we have to take that slide with a grain of salt because it's looking at retrospective studies over time. It's a meta-analysis, or they just took a bunch of studies, looked at it, and said, okay, we see this, there's an increase. But there's some that's drinking alcohol that's protective, and then not drinking alcohol is protective. You know, it's a little bit of plus minus. So I won't say we must do this, you must do that. I think normal BMI is probably good for you. Yeah.
Can a stroke trigger dementia?
So that's a good question. So one of the risk factors is vascular disease, and that might mean little strokes that have built up over time. One type of dementia is vascular dementia, where you've had multiple strokes that either are subclinical, that you don't notice. That's usually related to vascular risk factors such as diabetes, high cholesterol, high blood pressure, and you have this buildup of damage over time that you don't even notice. And we might just see it on an MRI because you're noticing cognitive problems. Or it could be the big strokes that you've noticed. You got weakness on one side, you had a stroke, maybe you had another one after that. That can cause cognitive impairment and then lead to a dementia. That's a vascular dementia. But it doesn't preclude you from getting Alzheimer's disease too. So you could have strokes and get Alzheimer's disease. I hate ending that way.
What would you recommend for aerobic exercise every week?
So there aren't great studies to tell you what kind of aerobic exercise as long as it's aerobic. So for people who are older, who have mobility issues, I often suggest things like a recumbent stationary bike. You won't fall off, you know, you can adjust the settings. Swimming, that's great. You won't worry about hitting your head, you know. But whatever you can tolerate. If you are walking, people ask me, is walking okay? Great, but walk fast enough so you can huff and puff a little bit, sweat a little bit. You know, I usually like to recommend 30 minutes every day so that if you have a day off here and there, we haven't missed too much. That research study that I showed you is, I think, 3 times a week. But I hate telling people that because I want you to do more, you know? Don't run a marathon every day, but do what you can tolerate or what your other comorbidities allow.
Hi, since alcohol is a drug that is ubiquitous and relatively inexpensive, can you talk about whether or not it might be helpful to have small amounts versus none?
Yeah. So one thing I would say, broad strokes. Alcohol may not be great for the brain in just broad strokes because although it relaxes you, it can impair cognition in a way that sort of, you're not paying attention, you're not remembering what's going on, you're not as focused. So in people who have memory problems, I would say avoid it as much as possible. There was a study looking at resveratrol, which is a component in, I don't know if it's just red wine, but wine, and looking at, for Alzheimer's disease, is it safe, is it tolerable? I don't think it demonstrated any effects on memory because it was just an early stage study. So it's possible that there might be some benefits the way red wine has been shown to be maybe potentially beneficial for cardiac disease or preventing that. But at least the amounts of resveratrol used in the study was more than you should drink. So I would not recommend necessarily drinking for the health of your brain. I would say don't drink for the health of your brain. Maybe there's small amounts that are okay, but I wouldn't say that it's good. Yeah.
Could you talk a little more about aerobic exercise? Does it correlate with a later onset of Alzheimer's? People with Alzheimer's who exercise, is the rate of progression slower? And what are the hypotheses why exercise should impact on Alzheimer's disease?
Sure. So in the study that I showed you, those are people who are normal who didn't have cognitive impairment. And people who do have cognitive impairment, it's showing less of a decline over time. There aren't as many studies that were as good as the one I showed you that were normal, but there are ones that are showing that there's less of a decline, meaning that it's smaller amounts of people that were enrolled in the study. The hypothesis is such that possibly there's something secreted when we're exercising, such as BDNF, brain-derived nerve growth factor, that might be stimulating the function of the neurons. And maybe that's making things regenerate, be healthier. I don't know if that's true. It's possible. People have looked at BDNF a lot in a lot of neurodegenerative diseases. We know that a lot of things are secreted when we exercise, like endorphins, that makes us feel good. So I wouldn't be surprised if that's it, or some other factors too, that are maybe antioxidant or something like that. Something that we can't recreate in a bottle, because that would be much easier to take than to exercise. But we have to do the hard work so far.
I have a question about misdiagnosis, because you touched on it a little bit. What if you misdiagnose someone with like a lower stage, like you said they had a lower stage of Alzheimer's, and they actually had a higher stage based on their like neuropsych kind of thing? What do you usually do in that kind of context?
you know, because we don't have disease-modifying agents, I don't think it's very detrimental in terms of treatments like medications. It's not like we've missed a window here. You know, oh, you should have been on this drug when you were actually on this drug. You know, I think it can change sort of the patient's and the family's perspective of where we are in the disease, what we should plan for the future, how we should handle things. That can be an affront to people if they're expecting that they're more advanced or they're milder. The only major thing that we have to do when someone has that dementia diagnosis is report people to the DMV. And so I tend to be conservative when I don't want to give someone a dementia diagnosis saying that something's non-reversible, non-curable. I want to make sure I have the right diagnosis. So I tend to be a little bit conservative saying that, well, I'm not quite sure yet. Let's wait and see. Or let's get some more tests before we jump there. Yeah. But I don't think we're missing too much except for understanding. Yeah.
Your statistics on the frequency of AD and other dementias, is that based purely on U.S. information? Is it worldwide? Any differences? And within the U.S., are there differences within different ethnic groups, for example?
Yeah, so that's a great question. And so I thought someone was going to ask me this, and I should have read this other article. So most of these statistics that I took are from the Alzheimer's Association. A lot of these are based on U.S. epidemiological numbers. But they are also worldwide. So I would say that, you know, I did give a number, you know, 35 million people worldwide. There are differences in ethnicities and racial backgrounds. So there was one study that was recently published, I think that was in conjunction with Kaiser and UCSF, and they found that in African-American population, there is a higher incidence of dementia than, say, Asian American population. But this is Asian Americans and African Americans, so not necessarily in different parts of the world. But they use the Kaiser study to say, you know, these are the same access to care because it's Kaiser. It's not like some people are less versus the other. Why is that occurring? We don't know yet. So there might be some cultural things, possibly. Could be some genetic things. We don't know. We do know things, for example, like, you know, there's always some island where people do great. So there's some island in Japan where they're all eating fish. I don't know. But they live, you know, there's a longevity there. And there's less incidence of dementia. Why? I don't know. Is it the lifestyle? Is it the fish? Is there something else? I don't know. But there are definitely some that are more at risk and some that are less. Mm-hmm.
What do you think the clues are in the new blood versus old blood? I mean, where do you think you ought to be heading in that clue?
Well, we all want to be young, but we can't be young forever. So, I mean, the goal is really to isolate what's in the young blood, and that's the research by Tony Weiss-Correa and his company. Essentially, he started in Silicon Valley. Everybody has their own company, so he has a company called Alka-Hest, and they're also working to identify or isolate what's in there. Are there some inflammatory markers that are a different profile in young people versus old people? That might be going to the anti-inflammatory question. Maybe there's less inflammation there. Maybe there's some healing powers. Maybe there's antioxidants. Maybe there's a protein, certain levels of different proteins. So it's really isolating that combination that would eventually maybe be used to treat not only Alzheimer's disease, but other diseases that affect us as we get older. I'm not sure. But for now, before we've isolated that compound, it's possible that just giving young plasma to people, maybe that'll help reduce the progression, improve things. We don't know yet.
Okay, I think we'll hold it at that. The end of May, we're going to have Dr. Jen Andrews, who's on the staff at Lucille Packard Children's Hospital, and her topic, and I hope we get a big crowd here as well, is women in medicine. And I want to thank Dr. Shah for a fabulous evening. Thank you so much.
Thank you for having me.